Thanks, Casey, and good morning, everyone. I certainly appreciate being part of this panel and this dialogue because the details matter. We certainly had a provider tax in Vermont, and I have to say to all of you, if you live through this entire discussion, I think you earn some sort of geek status or something. So this is a really tough one. And Vermont's provider tax was obviously smaller and much more simple, but again, we had the same mechanism and the same dynamics. Also wanted to thank Bill. I think you raised a lot of good issues, a lot of good information to kind of help better understand this very difficult topic. I think it takes a lot of washes to gradually work with this topic, and I look forward to the session as we begin the HCRA reauthorization. And certainly looking ahead, obviously in the HCRA reauthorization, we'll be talking about it in the context of the Affordable Care Act repeal and replace. And I know the next panel is going to talk about that, so I won't talk about it here, but obviously that political context is going to matter quite a bit. I just have 4 points. First one is HCRA is critical infrastructure. It is embedded deeply, and I think as Bill alluded to, there are other funding sources. This HCRA only provides some of Medicaid funding. So if you change HCRA, you by its very nature, you will be changing winners and losers for who gets the funding. You might be changing how the revenues are come into HCRA, and that in turn will affect other laws. So it's tread carefully, but it's critical infrastructure that New York State depends on significantly. And certainly making improvements is always the goal, but you first do no harm. Second point is that every state, except for one, Alaska, I believe, which has oil revenues, so they don't need some sort of a provider tax mechanism to generate federal Medicaid dollars. But every state except for one has some sort of infrastructure that they depend on to draw down those federal Medicaid revenues, and it's critically important to them. Third point, and Bill alluded to it, is the hidden tax aspect. I have called this the heroin of politics because legislatures become dependent on this ability to raise revenue when they have a budget gap, and they don't have to turn to taxpayers to actually pay for it, at least not that they know. And it is very, very tricky to unravel that dynamic, as I have learned in Vermont. And I think my fourth and most important point is that this mechanism would not be needed if all payers, including Medicare and Medicaid, covered the cost of the services that were provided. We would just have payment for services, and we would not have all this complication. Now, I realize that may be pie in the sky at this point in the universe, given what's happening in Washington, but I think it's a simple point to remember that we would not have all of these funding mechanisms and complications if all payers covered the cost of care. So, thanks.
Next up, we have Robert Hinckley, who is Senior Vice President for CDPHP, a 12-year veteran of that organization. He spent the past 4 years heading up corporate strategy development and governmental relations. He served as Senior Deputy Secretary of Health and Human Services under Governor George Pataki, which means he was present at the creation, as they say. And his resume also includes work for the State Health Department, the Office of General Services, and the Comptroller's Office.
Okay, so now that I've gotten the blame for all of this, I also want to test B's comment about being geeks. How many of you were here in '96 at the beginning of this? I don't feel so old, so okay, good. We're geeks. So HCRA was designed to bring competition and market principles to New York's healthcare system. It was a major step, I believe, toward deregulation. It was a promise George Pataki made during his campaign, and one he carried out once he got in office. It left, I believe, at the time, only one state still in a NIFIRM-like system, and I believe they're still there, Maryland. But it deregulated an industry that had been so highly regulated for decades. Money had to be used to fund GME, as Bill was talking about, ensure an adequately funded system so that we could prop up some of the ailing hospitals. And policymakers had to come up with another source, another funding source to help do that, and that led to the HCRA surcharges. As Bill mentioned, it did lower spending trends and save taxpayers money, and it continued the hospital safety net. It also, however, continued the practice of using private insurance to subsidize public needs, and that's gotten exacerbated over the years, as Bill so well put. It was a good law. It was desperately needed. But what it didn't do was contemplate some of the spiraling costs of healthcare in the next 2 decades, things caused by demographics, the aging of society and the needs of our society, the impact of poverty and the 2 recessions, maybe 3 that we faced since that time, increase in technology, which has driven healthcare costs, fiscal crisis, which were brought about by the environment, by the recession, other external affairs like external factors like 9/11. It also didn't contemplate the decline of inner-city hospitals and other public hospitals, or ACA and all the taxes that ACA brought with us. What it did do was force hospitals to be more business savvy. In my time in the governor's office, that became really crucial. Life was no longer built upon the cost-plus world of NIFRM, and that's a good thing. The hospitals that saw this and could invest in systems, business systems, not the latest in medical technology, which they all did anyways, especially those with market power, they did well. Those that didn't, and this is, I'll get to a point later on about some of the failings here, those that didn't ended up just getting bailed out by government. So politics started to take over policy. Go figure in New York. It kept New York's commitment to training great doctors, supporting safety net hospitals, and supporting public goods. But with many public programs, funding gets added but never subtracted. As a result, we've lost transparency, and I will state that I believe while HCRA isn't the most transparent, it's a heck of a lot more transparent than NIFRM ever was. It added spending insurance, ensuring efficiency, and it was used as a budget savior, as Bill so happily pointed out. The question is, can we keep doing this in the face of continued upward pressure on healthcare costs? Federal government imposed healthcare taxes. We all talk about the taxes as part of the Affordable Care Act. I believe that right now is a time that we really can take a good hard look at HCRA. Thankfully, it's up for reauthorization. Perhaps as the feds change ACA, we should look to change HCRA accordingly, not just reauthorize it. So what should we do? We should reduce taxes. Private insured cannot continue to support a 9.6% tax on top of already rising costs. I'll give you an example. CDPHP, my health plan, pays $93 million in taxes a year. We're not for profit. 53 million of that is HCRA taxes. That's a huge amount that we have to tell small businesses, large businesses, and individuals that's being added to their health care costs. To do this, we need a thorough re-examination of HCRA uses, including the transfer to Medicaid. Not easy, but something I think the time is right to do. We need, I believe, to reduce the indigent care expenses. I go back to '96, I still call it bad debt and charity care. More people are insured. Every day, the New York State of Health talks about all the new people being insured through the exchange, but we're still spending the same amount on indigent care. We have to understand and accept that not all hospitals need to be saved and don't need to be saved through HCRA. We're at an inflection point, I believe. We can change it and rationalize our system, or risk another few years of continuing to feed the HCRA beast. Or we might have to move to a hospital rate-making system a la public utility system, which I don't think would be a good thing. So thank you.
Next up, we have Elisabeth Wynn, who is Senior Vice President for Health Economics and Finance with the Greater New York Hospital Association. The association is the principal advocacy organization for some 300 not-for-profit and public hospitals and nursing homes throughout New York, New Jersey, and southern New England. Oh, sorry. There.
Good morning, and thank you for having me. As Bill laid out, certainly there's a patchwork of revenue sources that are embedded in HCRA, but I think in getting wrapped up in the details, sometimes it's important to kind of take a step back and remember what HCRA has helped us accomplish. Obviously, there was the deregulation of the hospital industry, but I think, you know, the other piece of it that gets a little bit lost is that New York really has been at the forefront of providing coverage to low-income New Yorkers, whether it was the Family Health Plus expansion that the HCRA tax has allowed us to fund, providing coverage to childless adults, helping to fund the Child Health Plus program and Healthy New York, all kind of precursors to the ACA. You know, if you look back 30 or 20 years ago, not 30, 20 years ago, our Medicaid program was about 3 million individuals. That's now grown to 6 million. Our uninsured rate is at a historic low with 5% in New York. And we know that there's tremendous benefits in providing coverage to individuals, whether it's better access to timely care, avoiding more expensive hospitalizations, and the difficult impacts on individuals of medical bills that they cannot afford. The other thing, just kind of pivoting to the realities of today, and Bea mentioned, you know, the pressures facing the industry, whether it's the hospitals or the health plans or other providers, from the unknowns associated with the activities that are occurring in DC at this time related to the ACA. With that backdrop, you know, I really think it's important to do no harm as we embark on this discussion. HCRA continues to provide critically important sources of financing. The indigent care pool is a very important source of revenue for hospitals that serve high Medicare, Medicaid, and uninsured populations. And I just, you know, before we even So I think it's important to kind of remember the context as we embark on this renewal discussion over this next session.
Excuse me. And finally, we have Kathy Preston, who is Vice President for Government Programs at the New York Health Plan Association. Prior to HPA, she worked for New York Presbyterian Hospital and at SUNY as Associate Vice Chancellor for Health Affairs. She spent 17 years in the state legislature, most of it working on the Finance Committee. Is that in the Senate? Yes. On health care, finance, and related policy issues.
Good morning. Thank you for inviting me to be part of this panel today. So Bob and I have the privilege of having been on the inside for a lot of this. I didn't actually hear anybody blame you for anything. You took that on yourself. And I will only take responsibility for those HCRAs through 2007. After that, it's not my fault. I also want to start by saying I agree with everything Bob said because he's the chair of our board at HPA. And I've got 4 points to make, really. The legislative intent of HCRA, which was drafted in 1996, is still totally valid today. It talks about New York State is experiencing dramatic changes in the organization and delivery of healthcare services, still true. These changes are occurring as a result of market forces such as the growth of managed care, still true. The integration of providers across the continuum of healthcare, still true. And the significant shift in the locus of healthcare from inpatient to outpatient settings, all still true. So the intent still stands. The implementation has traveled almost as far as you can go from the intent. So I think we can start with the same intent and try to work our way back to what we originally thought this should look like. Things change over a 20-year period, so it's not unreasonable to start from that point. The second point, HCRA may be transparent, but it needs a lot more transparency. I think it's opaque at best, and it should not be nearly impossible to determine how much revenue is coming in, how much money is going out, and what it's being spent on, what's encumbered for future spending, and what the fund balances are. 2 years ago, when the executive budget proposed a tax on plans to fund the exchange, we started a 2-month process of trying to get some sense of how much money was being spent. And it took nearly an act of divine intervention to pop those reports loose after several years of them not being shared with the legislature. Once they were popped loose, it was somewhat difficult to tell what was going on. The enacted budget financial plan for fiscal year 16-17 indicated a final closing balance in HCRA of $78 million. The comptroller's annual report for the same year indicated a closing balance of $774 million. Which one was it? And I don't think we know, and I don't think we can figure out what numbers match to what other numbers. So I think there's some work to do there. Also on accountability, I think we do need to take a look, as Bill so eloquently outlined, how this money is being spent. If the safety net is what we think we should spend the money on, then I think we need to figure out how we're going to define the safety net. If we need to line up the amount of money that the public hospitals are getting, fine, let's see what it all looks like. Let's do the chart with all that money on there and see what it looks like. So I think we do have to have that conversation. And finally, all of this needs to be reviewed in the context of what may or may not be coming at us from the federal government. We really can't determine what we're going to do with this revenue or what we're going to do with these programs until we see where we're going. I would argue that while other states may have taxes like this, I'm not sure any other state has the equivalent of a $66 billion Medicaid program. California, about twice the population, about twice the number of people on Medicaid. We spend 2/3 of what they spend, not 1/2. So I think we've got to take a real hard look at everything we do and what's the best use of the funding and what are the best sources to get the funding. Because as Bill said, first do no harm, we have got to start getting a handle on the whole program instead of doing things that continually increase the cost of coverage for everybody. That's it.